Acute pulmonary thromboembolism is the third most common acute cardiovascular disease after MI and stroke, and it can be fatal if not diagnosed and managed on time. Hello friends, I am Dr. Anshika Gulati from National Heart Institute, and today I'll take you through my approach of evaluating a case of pulmonary thromboembolism on CT pulmonary angiography. This was a 42 years old gentleman who presented to us with acute dyspnea and chest pain. His D-dimer levels were raised. Acute deep vein thrombosis was seen on lower limb Doppler studies. Chest X-ray was unremarkable. We did a CT pulmonary angiography and we'll see the findings. This is one disease entity that affects three systems, so we'll discuss the findings under three headings: the vascular findings, the pulmonary findings, and the cardiac findings. Starting with the vascular findings, this is the main pulmonary artery bifurcating into the right pulmonary artery and left pulmonary artery. This is a filling defect in the distal part of right pulmonary artery. This is a filling defect in the distal part of left pulmonary artery and extending into the lobar as well as the segmental branches. This is the lower lobe branch, the filling defect in the center. This is called the polo mint sign with the filling defect in the central part of the artery and the contrast all around it. This is called the polo mint sign, classical for acute pulmonary thromboembolism. Follow this filling defect. It is extending into the lobar as well as all the segmental branches, the anterior, lateral, medial, posterior, all the segmental branches of the lower lobes. The filling defect. Coming to the upper lobe, the filling defect is extending into the upper lobar branch of left pulmonary artery as well as the segmental branches. Coming to the right side, this is the filling defect which is mostly in the central part, and in the periphery, if you see, it is forming an acute angle with the vessel wall. So this is acute pulmonary thromboembolism, and on the right side also it is extending into the lobar as well as the segmental branches. This is the right lower lobe branch of pulmonary artery, and the thrombus is extending into the segmental branches as well. The middle lobar branch, medial and lateral segmental branches. Coming to the upper lobe, this is the lobar branch of the right upper lobe pulmonary artery, and the filling defect is extending into the segmental branches of the upper lobes as well. This is the filling defect. So this is a case of acute pulmonary thromboembolism. Whenever you see such a case, you have to give three classifications. First is the spatial classification, in which you have to tell which all arteries are involved: the main pulmonary artery, the right, left, lobar, segmental, and which all of these branches are involved. That comes under the spatial classification. Second is the temporal classification, in which we tell whether it is an acute thrombus or a chronic one. For that we use certain signs, starting with the acute. If you see a vessel that is completely occluded, but the diameter of the vessel, the caliber of the vessel is wider than the patent adjacent vessels, then that is a case of acute pulmonary thromboembolism. Second, if the vessel is not completely occluded but partially occluded and the filling defect is in the central part of the vessel, like in this case, it is forming a polo mint sign. That is also a sign of acute thromboembolism. And if you see this vessel on the long axis, you will see a tram track sign. And thirdly, if the filling defect is in the eccentric part, it will form acute angle with the vessel wall. So remember these three signs of acute pulmonary thromboembolism: dilated vessel with complete occlusion, central filling defect forming the polo mint sign or tram track sign, and eccentric filling defect forming acute angle with the vessel wall. Coming to the chronic thrombus, if you see a vessel is completely occluded but the caliber of the vessel is narrower as compared to the adjacent patent vessels, then it is a case of chronic thromboembolism. Or if there is a partial occlusion, then the thrombus will be in the eccentric part forming obtuse angle with the vessel wall, and there will be signs of recanalization and organization like fibrin strands or calcification. And finally, you can also see some bronchial or systemic collaterals in a case of chronic thromboembolism. This is the temporal classification. Third is the hemodynamic classification, for which you have to give a clot load score, in which what do? We evaluate 10 segmental vessels on the right side and 10 segmental vessels on the left side. And for each of the vessel, we give a score of 0 if there is no occlusion, 1 if there is partial occlusion, and 2 if there is complete occlusion. And for the central vessels like the lobar or the right, left or main pulmonary artery, we give the number according to the segmental vessels distal to that central vessel, and again 0, 1 or 2 depending on the type of occlusion. So 10 on either side with a 2 maximum, the total maximum score becomes 40. So you calculate the score in your patient, and you can even give the percentage involvement by dividing the CT clot load score in your patient by 40, that is the maximum total score, and multiply by 100, that will give you the percentage involvement. So this is, we are done with spatial classification, temporal classification and hemodynamic classification, giving the clot load score and percentage involvement. Other vascular signs can be, sometimes you can see findings of pulmonary artery hypertension because there is occlusion in the arteries, so there will be raised pressure in the pulmonary arterial system. You have to take the diameter of the main pulmonary artery at the level of bifurcation, and if this caliber is more than 33 mm, you say there is pulmonary artery hypertension, which is not seen in this case. The caliber is within normal limits. If it is dilated, we see there are signs of pulmonary hypertension. This is all about the vascular signs. Now coming to the cardiac signs. Because of the increased pressure in the pulmonary arterial system, we can see findings suggestive of RV strain also sometimes. The best evaluation for RV strain is done on echocardiography, but definitely you can see certain morphological signs on CT as well. If you take the transverse diameter of the right, the short axis diameter of the right ventricle, and you compare it with the short axis diameter of the left ventricle. If the right ventricle is dilated as compared to the left ventricle, you say there is RV strain. We can see on the short axis view as well. This is the right ventricle, this is the left ventricle. Definitely the right ventricle is dilated. Normally LV should be rounded and wider, and RV should be concentric and narrower. But in this case, the relationship is reversed. So we say there is RV strain definitely in this patient. Second is the interventricular septum. There will be straightening of the septum, or the septum can be deviated towards the left side. So we say there is RV strain. And third finding, if you see reflux of contrast into the IVC and the hepatic veins. So these are the three signs of RV strain: dilated right ventricle, deviated interventricular septum towards left side, or even straightening of the septum, and thirdly the reflux of contrast into IVC and the hepatic veins. So we are done with the cardiac signs. Coming to the pulmonary signs, you can see three findings. Either there will be mosaic perfusion, which refers to the alternate brighter and darker areas with a geographical margin in between. The that is not seen in this case, I am just explaining. The hypodense areas are hypoperfused areas, and the caliber and the number of vessels in the darker areas will be lesser as compared to that in the brighter areas. That is mosaic perfusion. One pulmonary sign. Other signs you can see, there will be a peripheral based wedge shaped opacity, like in this case that will be a pulmonary infarct. And third finding, like in this case, there will be alveolar opacities. This is ischemic pulmonary hemorrhage because of pulmonary infarct. Sometimes in acute cases it may be difficult to distinguish between ischemic hemorrhage and infarct. So if you do a follow-up scan after 1 week, the hemorrhage will be resolved while the infarct will persist, and ultimately it will lead to scarring. So Just to revise, the vascular signs, the cardiac signs, the pulmonary signs. Within the vascular signs, spatial, temporal and hemodynamic classification, giving the clot load score and percentage involvement, commenting about the pulmonary artery hypertension, then telling about the cardiac signs, commenting about RV strain. Coming to the pulmonary signs, mosaic perfusion, ischemic pulmonary hemorrhage and pulmonary infarct. So that is all about our approach to CT pulmonary angiography in a case of suspected pulmonary thromboembolism. I hope this was helpful. Thank you very much.